Great. Thank you so much, Sarah. As Sarah said, my name is Liddy Garcia-Bunuel. I'm actually a Baltimore City resident. I work for a company called Health Management Associates, have been a principal for the last 8 years in Baltimore City, but have worked nationally on a lot of opioid prevention response work, really rooted in community-based work. So sort of co-design with community around addressing the opioid crisis in their own communities. So I'm here today to talk to you all. And again, I really want this to be a conversation. Don't want this to be didactic, but I have a few slides just to talk a little bit about the data. And it's funny, Sarah, I was thinking that this was going to be Maryland specific because you are leading age Maryland, but seeing that there are people from all over the country is very interesting. So I see that there are people from Ohio, Missouri, Chicago, Baltimore. So, and I'm sure that there are, and I see Reading, Pennsylvania, Connecticut. So really interesting to see how many of you are calling in from all parts of the country, which I think will enrich the conversation that we hopefully will have today. Unfortunately, some of the data is going to be specific to Maryland, but I would imagine that this is national as well. I think from an overdose perspective, I would imagine most of you are aware that we have had quite a crisis here in the United States. Initially, it started off with an over-prescribing practice by our providers, and not sort of, again, that's why there's so many opioid settlements that are happening currently, with a lot of the pharmaceuticals pushing out opioids, again, an over-prescribing. And then a lot of the prescribers have been educated about the addictive quality of opioids, pulled back on their prescribing. And then there were still a lot of individuals that had an addiction and moved into sort of the street drugs of using heroin and others, and even pills that you could get on the black market. And then we had this huge influx of synthetic opioids. Many of you may know fentanyl that has come in. That's really, again, it's a synthetic that is much more powerful and strong, and so has really been the cause of many of the deaths that have occurred across the country. So what I want to do again is I'll share my screen. But I will also, let me just put it in the right mode here. Let me put it into PowerPoint mode, and then let me switch okay. Can everybody see this okay? Okay, great. So again, I note this is a conversation and this isn't just a presentation by me. So at any time, please interrupt me. You raise your hand, ask questions, whatever, just so that this can be a conversation. So I really wanted to talk about today harm reduction, and specifically the rise in opioid use among seniors. We wanted to share with you the latest data, and then sort of how to be better prepared and some of the barriers and challenges that you're seeing in your own states and in your own housing communities. So in Maryland, you can see the purple line at the top is representing the age 65 to 74. And the change between 2019 and 2023 is 92%. So it's a significant change, and something that I think everyone in Maryland has their eyes on, just to sort of understand this population, again, the age of 65 to 74, and why there's such a huge increase in overall opioid overdose fatalities. We can also see in the age group of 55 to 64, the non-Hispanic Black has the highest, and by a lot, death rate per 100,000. And this was in 2023. And you can also see here that they're in the non-Hispanic Black communities. And again, this is specific to Maryland. Between the ages of 55 and 74, you see that there are increases and there were decreases in the non-Hispanic white communities. And then specifically in Maryland, representing 89% of the state counts, 76% of them were in Baltimore City in terms of the fatality counts, and 7% were in Prince George's County and 6% in Baltimore County. And this was for the non-Hispanic Black community. And then for the non-Hispanic white community, representing 55% of total state, 27% were Baltimore City, 19% in Baltimore County, and 8% in Anne Arundel. The substances, this is my last slide, and I want to just, sort of make sure that everyone's aware that, probably 10, 15 years ago, people may have been dying with some heroin, which is down here on the right. And now with the synthetic opioid fentanyl, you can see that in the non-Hispanic Black community, 55 and older, 98% of the deaths, fentanyl was involved. And for the non-Hispanic white community, 55 and older, 86% of the deaths, there was fentanyl involved. So the next slide, I want to talk a little bit about how to be better prepared as service coordinators or property managers or any staff that are in some of the housing communities in all the different areas that you represent. So I think the first thing is really understanding that there are Good Samaritan laws, and this is specific to Maryland, but I think all states have a similar Good Samaritan law that protects you and make sure that you don't run away from the scene. A lot of times earlier on, without these laws, if someone overdosed, people would flee the scene and no one was getting assistance for that individual. The good news is there's actually, with an opioid overdose, there is actually a reversal agent called naloxone. And so staying at the scene and being able to call 911 and ensure that person is getting what they need to stay alive is something that we're obviously encouraging and recommending. And even if the person is using with that person, they won't be charged depending on the amount, but they won't be charged. They will be protected in terms of getting arrested. So one thing I wanted to talk about is just some general information about overdose, and then I'm going to pause and stop sharing my screen and sort of get a sense from all of you what you all have been experiencing. The signs of an opioid overdose is, these on the left: loud snoring, lips, fingernails turning blue, which means you're not getting oxygen, pale grayish skin, unresponsiveness, a very limp body, shallow, slow, or stopped breathing, and slow or stopped heartbeat. And so once someone has identified that this person is experiencing an overdose, these are the recommended steps. So the first thing you do is you want to try to wake them up. You want to try to get their attention. We call it a sternum rub. You want to sort of make sure that they're not just sleepy or whatnot, but that if they're not able to wake up and they're not responsive and they're not breathing, the first step would be to call 911. And sometimes this happens simultaneously. So if there's two of you responding, one can call 911 while the other person is giving naloxone. And naloxone is the reversal medication. It looks like a nasal spray. It looks like a Flonase or anything like that. And I'm going to talk about how to get it in a second. And you basically, it's in a little container. You peel it away, and then you actually lay the person on their back, and you put the nasal spray up one of their nostrils. And then you basically wait, put them on their back, and you support breathing. A lot of times people aren't comfortable with this step, and that is fine. Sometimes if it's a family member or a close friend, I think people are more inclined to be able to support breathing and potentially give rescue breathing. At this point in time, the person is not breathing, and so they're going into a state of hypoxia. And so anything that they can do to get oxygen is helpful. And so even if when 911 is there, it's actually really helpful because they can use one of those face masks where they can give them oxygen. And then after 3 minutes, and it's a full 3 minutes, you can give another naloxone dose if they still are unresponsive on their other side, on the other nose, or their other nostril, and then put them in the recovery position until help arrives. So those are the typical steps of responding to an opioid overdose. And again, one of the best things about this is that there is something to do to keep someone alive. And the other thing is, if someone is not having an opioid overdose and you're not sure, giving naloxone is not going to hurt them. So that's, another thing that a lot of people ask questions about. So I'm going to actually stop sharing my screen. Every state has, you can Google, and every states operate the ability for people to get free naloxone through different programs. You can also get naloxone at pharmacies because it's over the counter now. It is not a prescription. So you can go into a pharmacy and get it off the shelf, as well as in each state, you can go and, you can inquire about getting free naloxone. And like in Maryland, they have overdose response programs. And if you, and I can put this link in I can put the link in a second into the chat. And for people who live in Maryland, you can go there and it has a list of all of the overdose response programs where you can get naloxone for free. So with that, I'm going to stop sharing and ask for questions. I would love to hear about your own experiences, whether you have, and again, whether you are in your, whatever state you're in, when you, if you're about to start talking, it would be great just to say where you're from again, what state you're from, and then any questions, and I'll monitor again the chat to see if there's other specific questions, but would love to get not only questions, but comments. What are you hearing? What are you seeing? Are you noticing a rise in your properties in which you're staffing? Are you hearing about it, but not seeing it? Have you, anything? And so we would love to hear from all of you. And additionally, what support what you may need in order to make sure that you're best prepared.
Liddy, we have a great question in the chat from Joanne. What if a person is a DNR? Do you still give Narcan? How does that work with state regulations from some licensed personnel that cannot, quote, assist?
It's a really good question, and it's almost a legal question, and I'm not sure I should answer. DNR obviously is a really important part that's a part of a medical record, and for a lot of people who are end of life or have a chronic disease, have chosen to do not resuscitate. And in this situation, I think I'll have to pass on that because I'm just not sure. One, if you would even know if the person is DNR, and if they are, and they've been very clear that they don't want any resuscitation, you're not I don't know. It's a good question. I don't know if Sarah, you have any thoughts on that either.
No, I'd agree that we'd have to certainly want to consult legal on that.
Yeah, I think it's a great question. I see another one on using a fentanyl test strip. So fentanyl test strips, so we distribute a lot of fentanyl test strips. There are two, I would say, types of users. There are folks that are actually seeking fentanyl because that's what they could buy, and it's potent and it's powerful, and so they will not be testing their supply because they're actually seeking it. When you do, for the folks who are actually attempting to like, they're more the naive users that think they're using one substance, but because there's so much substances, like someone who may be using crystal meth or anything else, right now there's so much of the supply that has fentanyl in it that they're not even aware they're taking fentanyl. So for those folks who think they're taking one thing, or, you know, for them to test their supply is a really good idea. The fentanyl test strips test either positive or negative. It's not going to tell you how much fentanyl is in the supply, but what it will do, and I'll talk about how you use it, is say that there's fentanyl in the supply, and that either don't use it or go very slowly when using. So it's a depending on who the supplier is, it's basically looks like a pregnancy test, if you will. And so you take some of the supply, whether it's powder or whether it's a liquid, and you, like if it's a powder, you just take a little bit and you put it into like a bottle cap full of water to mix it up, and then you put the test strip into the water that has some of the powder or the liquid. And when you dip it in, it'll say whether there's fentanyl or not. It's sort of like, again, a pregnancy test. So, and there'll be very clear instructions on the fentanyl test strip on what is designated positive or negative. And that's how you test your supply. And the fentanyl test strips have been proven to be very effective in working to test whether there's fentanyl in supply. I've been asking this and not getting answered. So Joanne is saying that about the DNR. Yeah, and I don't know, Joanne, if you want to talk about that at all with the group, but I would imagine that that's a tricky one, and I'm not sure how might we get a response on that one.
Joanne, you're from Rhode Island, is that correct?
Yes.
Okay. Okay. Let me see if I can do some digging of some legal there in Rhode Island. I've made a note, and we'll try to follow back up with you. And certainly if we hear anything, yeah, we'll follow up with the rest of the group, because I think all of us would have that question.
So what experiences are people having? And I would love to hear you know, from all the different states that are on, in terms of whether this has been something that they're seeing and that they're not seeing, and how you all have responded or not responded, and just sort of just your general experience. Anybody want to take off, be bold and take off the mute and share your experience? I might have to start calling people out. You know, just to sort of see, actually, why don't I do this? Let's, is anybody taking themselves note? I saw that there were some people from, I think it is Jan Pennington. Jan, are you willing to talk a little bit about your experience in Baltimore as a service coordinator with Catholic Charities?
Hi, everybody. I was just writing into the chat. One of the situations that we had here is a resident was on methadone, a regular dose, for over 40 years. And then when COVID hit and his primary physician was not seeing him every 30 days, he resorted to heroin on the streets down near Pimlico, which can be kind of a dangerous area. And I didn't know that his apartment is like right across from my office, and I didn't know that he had been using. But he didn't show up for lunch one day. We had an eating together program, so we knocked on the door and he didn't answer, and we went in, and he was doing the really hard snoring, and we had called 911, but that ends up what it was, that he had overdosed. And I mean, I never even had a bagel until I was in college. So like this whole thing was so new to me. I was scared to death. He did come out of it. The Narcan woke him right up. but it was something I didn't expect here in the suburbs. And I do have other people who are on methadone for a long period of time. I just wondered maybe if you could talk about long-term methadone use. And I'm not talking just a few years, I'm talking decades long. So thank you.
Jan, thanks so much for sharing. And I think that that's not, it's so traumatic for you to have experienced that, and other neighbors that may have seen that and experienced it. So thank you for sharing that. So there are a couple different treatment options. There's methadone, and then there's what we call Suboxone or buprenorphine. That is called, we call it medication for opioid use disorder. And I know during COVID, it was challenging for folks to get their dosage just because things were closed down. I think they tried to do more MAT or MOUD services. But for folks to be able to not be able to access methadone obviously was hugely challenging. For those who don't know, when you're going off your medication, or you're going off of opioids, it feels like you have the flu. And the only thing that you can think about is getting your next round of medication or your next dose of opioids. And so it's really about the dopamine receptors. And it's sort of just, that's the only thing that you can do. I think there are some people that can take a medication for 3 to 5 years and wean off of it with their provider and their prescribers. Some folks will be on it for life, for forever. And it really depends on the individual. So we've been told that working hand in hand with the your prescriber, the provider who's treating you for your medication, for the MOUD program, would work with you. And I've talked to many people that started, and after 5-7 years were able to get off the medication. And again, there will be others that will need to stay on it forever until they pass away. And a lot of it has to do with stressors. So if you lose a job or you lost a family member or a friend, the stressors are really challenging. And so, and I think for seniors in particular, it's a really hard time. There's isolation. There are people who are, your friends who are dying, you're feeling disconnected. And so I think it's a particularly challenging time. And so to maintain your medication, I think for opioid use disorder is absolutely critical during that time. Jan, did that help at all?
Yeah, thank you so much. I appreciate it. So if you see like that a person is on the methadone for a long period of time, you should just kind of go with it and let them work with their primary doctor, and that's, I guess, basically all you can do.
Yeah, and so they'll be methadone is through what we call an OTP, so it's a opioid treatment provider, and so they're regulated federally, and so and they have their own requirements, and so if they're on methadone, they typically have to go every 1 to 3 days to get their dose, and it's very regulated. And then Suboxone, or sort of buprenorphine on the other side, is you can get it with like a film or a pill, and that can be prescribed by your primary care provider or other providers. And so there's two sort of different pathways. But for someone who's been on methadone for so long, most likely they would just stay on methadone. And I think part of it too, I would imagine, is transportation issues. And so if people have to go daily or every 2 to 3 days to get their dose of methadone, that can be really challenging.
That's what I was going to say. This person, when he came back to the apartment, he was enrolled in a program, and we are pretty far out. We're in Baltimore County, like almost into Carroll County, and there's really not a lot of transportation options. And it was really hard when they finally trusted him for like 2 days, we were really happy. But a lot of times he would just be like scrounging for transportation, and we try to get things set up. But it was really hard, and also for low income seniors, really expensive. If you can get on one of the transportation, paratransit, that kind of thing, it's not so bad. But like if you're asking a neighbor to take you someplace like that, they're going to charge, $25, $30. And it was really just really unaffordable for them afterwards. It
And
was
Jen,
just,
that's
yeah.
really important because I think having someone go daily to get a methadone dose is really challenging for someone who has limited income and is not close to OTP where they actually do the dosing. So really good feedback. And I think something that, we should really try to think through.
Thank you.
So what about other states? What are other states experiencing? Any other similar experiences to Jan?
I had a specific question for the group. Oftentimes, I know there may be a few folks in rural areas that are joining us. Oftentimes, there's a lot of services in and around the cities, but we know that there are significant challenges in rural areas as well. Would love if there's anyone joining from a rural area to share your experience. Or feel free to also put in the chat as well.
I have a question. I can't speak to the rural areas. I mean, we're kind of suburban here. But I wonder with the statistics that you showed so far, like, or what who administers the Narcan mostly? Like I see articles that librarians now have it, and a lot of places where homeless people might congregate during the day or in the evening, that workers there have it. Can you talk a little bit about like who has the Narcan and how it's being administered?
Sure. So actually, I just saw something yesterday on the local news here in Baltimore that more and more lay people are administering naloxone. And as a matter of fact, I'm hoping I'm getting the statistic correctly, but by the time 911 arrives to the scene, 42% of the times it's already been administered by the time they get there, which is great news. So naloxone is every state has a standing order, and people like you and me can have naloxone on them to carry. So if you are ever working or residing or have friends who may be at risk for an overdose, you can have naloxone and carry the naloxone with you and administer it. It's such an easy medication to administer that there's been a huge push to ensure that lay people have access, know how to use it, and can administer it. So it's safe to say that definitely any first responder is going to have naloxone, period. So whether it be fire, whether it be, the paramedics, whether it be the police, they all have it. In addition, there are lots, like as you mentioned, Jan, more and more times, like public libraries have naloxone. We're finding that it's a place where sometimes people go into the bathroom and may use in the bathroom, and so librarians and staff there have naloxone to be able to administer, and some of the libraries are actually distributing it as well. And basically anyone, if they're distributing it, you can go up and ask for naloxone and they'll give it to you. What we have I've worked with a lot of communities where we're trying to get it everywhere, so that and well, I shouldn't say everywhere, in places where we think there's a need, because there are populations in that area that are at risk for overdose. So, so we're, we've had grocery stores have it. We've had different stores, thrift stores have signs that say, we have naloxone, free naloxone here, get your naloxone. We've had, food distributors have it, so when people come and get food, that they can also get free naloxone. So we've made sure that entities that are working with people potentially at risk they have bulk naloxone and they can distribute it. So they can do a quick 3-minute training on how to use it, and then they distribute it. So if anybody knows or recommends any entities where your residents are coming into, frequent contact with, where they may want to be able to distribute, that's great. Or being able to understand who's what we call in Maryland, Jan, overdose response program. They call them ORPs, and there are hundreds of them in the state of Maryland. And so, Jan, actually, I was going to put that link in the chat. You can go and you can see in Baltimore County, Jan, who is an RRP, and then you can have them even come to your facility and have residents get naloxone for their own use and for use with their neighbors.
Liddy, there's Jan wrote in, one of the residents here said she was required to get naloxone when she saw the pain management clinic. She said that it cost her $42. Does that seem right from a pharmacy to charge that much when it seems like you could get it just about anywhere for free?
Yes. So they call it co-prescribing. And so it's a best practice now. So if you're getting referred for pain management and you're on any kind of medication, they will co-prescribe naloxone. So you have naloxone. And if you're going to a pharmacy to get naloxone, the $42 is about right. Now, if you have insurance and you say it's for yourself, typically the copay is much less. And so it can be down to even zero. So it depends on your insurance. They would probably cover the cost. And so if you weren't using your insurance, it would be $42. That's the cost of it at a pharmacy. But if you were using your insurance, the copay would probably cover it. So I noticed that there was someone on from Ohio, and I know Ohio is also sort of an area where there's high overdoses. And I'm wondering, and I think it's Christine Day. I'm wondering if Christine, do you have any stories from Ohio? And if you've experienced anything like Jan has? Oh, Jeffrey. So it looks like, so Jeffrey, you have your hand up. I'll go ahead and call on you.
Yeah, I just had a question for the group, the $42 thing. Is there a hardship application that I don't know any residents or folks that use it, but sometimes drug manufacturers have a hardship application where it gets subsidized, if that's correct? And, we deal with the underserved population where they don't have a ton of bucks.
That's right.
It may never hurt for an RFC to give a hand, or if the resident can't, or the local resident, the folks from the local area can't do it themselves.
Yep. So the $42 is really the over-the-counter cost. So my advice would be, if your residents have Medicare or Medicaid, that they should use their insurance to get it, because the copay would be, I think, zero. So I think that would be the best way to do it. However, the other thing is, the person I referred to does not have a prescription D program. Okay, so if they don't have a prescription Part D, then medications are not covered. And so, but if they have a Part D, now if they're not covered, the other thing that I would highly recommend in all of your housing communities is, if you're seeing, even if there's like you've experienced one overdose in your building, or you know that there are people potentially at risk for overdose in your building, especially with the rise of opioid use within the senior community, reach out to your county or state health department. They can give you a list of entities that provide free naloxone. Invite that entity to your housing community, get residents trained in understanding what naloxone is and how to use it. They will leave free naloxone behind, and then you'll have access, the residents will have access to naloxone. And when you run out, call them back up again and they'll come back, right? And they'll give you more naloxone and make sure everybody's trained. So that is exactly, for people who have limited income, you should not be buying it for $42. They absolutely should be getting it for free. And there are specific entities in each state that give it out for free. Christine did say, I had one overdose. We called 911 and they gave the Narcan. We do not have any here, but you can get it for free. Great. So, and Christine, I'm not surprised. I would imagine maybe everyone has experienced something like that. So again, my recommendation would be to reach out to either your county, you can Google it. It's pretty easy to find. If you say, where can I get free naloxone, right? They'll give you typically a list of entities that have free naloxone. And if you reach out to them, they can come to your property and be able to do that education for your residents and be able to give you free naloxone for your residents. And Narcan is available for free. Yes, there is a high number in Ohio for sure. With some settlement dollars that are landing as well, there should be even more access to naloxone. The other thing I want to talk about is a little bit about the stigma within your housing facilities. We really want to make it a universal offering as much as possible. So you don't, people who may be using may be ashamed and may be doing it behind closed doors and doesn't want anybody to know. And so being able to, ensure that when you're offering it, you're not saying, well, you should do it and you should do it, but it's really about you're getting it to save a neighbor's life as well. So even if it's not you and you're getting it, it could be for anyone within the building, and people in the building are at risk for an overdose, and sort of explain it that way so that people feel comfortable getting it. And so that they're not being like, oh, I need it because I'm using, but I need it because maybe my neighbor is at risk for overdose and I need to have it. So I think that's an approach that I think is also super important. So yeah, Christine, thanks for your comment there, because I know that that's really been challenging in Ohio. Any other, let's see, what if older adults are in hospice care diagnosed with substance use disorder with opioid dependence? How do opioids interact with morphine? That is a really good question. When they're in hospice care, and this has been something that has been really interesting. I do a lot of work in Delaware, and as seniors are aging and they have a substance use disorder and they go into assisted living or they go into skilled, a SNF, a skilled nursing facility, or even in hospice care, for a long time, they didn't even offer any kind of like medication for opioid use disorder. And now they're starting to do that. But everything that's being given to this patient should be monitored by the prescriber. So by the prescriber who's prescribing morphine should know if this person is taking medication for opioid use disorder or is continuing to use opioids. That prescriber needs to know, so that when they are giving morphine or any other drugs, they need to know how it's going to interact with what they're currently taking. So that person needs to be completely open and honest about what they're currently taking, so that whoever is prescribing morphine is aware, so that they don't have any kind of counterindications. The other question I had for all of you is, seniors are really complex, meaning that there's a lot of, sometimes people are suffering from a chronic, back pain, or there's an old injury that they had. And so there's some physical challenges. And as people get older, they're, maybe have arthritis and things that they're trying to manage themselves with pain and with some opioid use, and also isolation and loneliness and losing friends as you age, et cetera, is a really challenging time. And so I think that being able to overcome some of that, and I think what seniors are recognizing that is using opioids is sort of takes away some of the pain and takes away, and I think that that's super challenging for seniors who are going through this and have an addiction that's been hidden for a long time, and now is sort of, it's scary because the drug supply has changed. And so previously they used to be able to purchase pure heroin and know how to use it, and now you can't find heroin's all got fentanyl in it. And so a lot of the seniors are, may have an addiction and are really challenged with finding something that's not going to kill them. And so I think it's really scary to be a senior and not having a supply that they can depend on. And so I think it's really scary. And so understanding harm reduction and supporting with, compassion, I think is really important. What else can you tell me about the senior population? Anything else in terms of what you have learned about working with seniors, and specifically around opioid use disorder? Is there stigma within the population? You can put in the text or whatever as well.
I know we have a clinic around the corner, and we do have residents, I believe, going there. I don't have, it's probably more an RSC area. I mean, they have to meet a HIPAA that we don't as a manager, but you're not going to run around and say something either. You're not going to ask them, but I know they go there because you drive that road on the way home. But you're right. There is a stigma. That's not something you discuss with residents and so on. Other stuff, food insecurity, these types of things. You don't bring up, hey, how's your addiction going? It's like mental health. It's something you don't bring up.
Yeah. And that's really interesting. And what do you think Jeffrey, if you were able to offer naloxone to all residents, or have like a basket on your front table, do you think that people would be open to receiving that?
I really do, because it's the transportation issue as well. When I say next door, it's probably a mile and a half from here. Oh. So if you're huffing it, as the term would be, it's not easy for somebody to get there, and it's not a lot of folks have cars either. Public transportation, there's free transportation if you're at that certain income level, but you have to coordinate it.
Wow.
Yeah.
Are other people experiencing that? It looks like, Jan, that we seem to have several seniors whose children have been drug users. I try to make sure we have a robust drug take back program so that their apartments don't have a supply of pain medication that might be accessed by family. It's a really, really good point. I used to do a lot of work with seniors and do like a medicine reconciliation. And as you all know, there's so much confusion around what medications to take and when to take them, and what's expired, what's not expired. And if you go to anyone's medicine cabinet, you probably would find enough opioids to, have no pain for 3 years. And so, because again, there was such an overprescribing. And so I totally agree with Jan that if you could do any kind of take back day, so a lot of local police departments or fire departments sponsor them, and you can have a day where they come in and all the folks can bring down their medications, their opioid medications, and dispose of them properly is 100% a really good idea. And I think that is a great way to just rid their, and the other thing, I think just general confusion, if there are opioids in their medicine cabinet and they think it's one medication and they're taking too many opioids, that could be another issue with an overdose. And so I just think that clearing out opioids from the medicine cabinet is a great idea. So Jan, thank you for that. And I think that's, I would highly recommend that practice. Anything else? Because I think we'll probably shut down in a couple minutes, but would love to hear any other experiences that you all are having in any of the states.
I was gonna say one thing. We have a health department, the regional health departments in Connecticut. And I'll talk to the RSC about actually seeing if we could get an individual from there to have a conversation, because I never thought about that. See, you learn something every day you're on a leading age event.
That's great, Jeffrey. Yes, and I would highly recommend that. And your local health department, if they can't do it, they will find someone for you to be able to have someone come in and talk to your residents and be able to give naloxone.
Thank you.
Yes, absolutely. So Jeffrey, that might be the best way to end. So I think, again, I thank you all so much for attending today. And I really support all of you and the work that you do. I know it's hard work. I used to work with service coordinators in Maricopa County in Arizona. And I really respect the work that you're doing to support residents in the housing communities. So thank you for your work, and wish you all the best. I would highly recommend that you find someone to come in and give your residents free naloxone, and make sure that everyone's equipped to respond to an overdose. So thank you so much for your time today. Really appreciate it.
Thank you, Liddy. We appreciate you being here with us, and thank you everyone on the call. We'll be sure to send out the recording for everyone so that that's accessible. Have a good rest of your day.
Thank you, Dee.